Skinolight, mixed UV visible light phototherapy in the treatment of skin diseases of allergic and immunologic origin. The effect of sunlight in the healing of various skin diseases of allergic and immunologic origin has long been known to mankind. In ancient times, Hindus knew that apart from using extracts of different herbs, exposure to sunlight has a favorable effect in the mitigation of vitiligo symptoms. Sunlight contains several components of the electromagnetic spectrum. In addition to visible light, it has ultraviolet A and ultraviolet B, both significant in dermatology, and infrared radiation, which is responsible for heat. Modern dermatology primarily applies the immunosuppressive effect of ultraviolet light for therapeutic purposes. This can be explained by the diverse biological effect that also involves the DNA in cells. There are a number of different medical phototherapeutic devices that emit ultraviolet B and/or ultraviolet A for the treatment of psoriasis, atopic dermatitis, and vitiligo, which constitute the main indication areas for dermatological phototherapies. Ultraviolet B is normally used on its own, while ultraviolet A is applied in combination with ultraviolet B or photosensitizing substances. Some of these instruments are capable of treating the whole skin surface in a cabin. Others provide local treatment in cases when the given skin disease affects only certain parts of the body. The Skinolight phototherapy. Skinolight is the first dermatological phototherapeutic device in the world to contain a combination of ultraviolet B, ultraviolet A, and visible light. The light emitted by the device has proved to be effective in the local relief of psoriasis, atopic dermatitis, vitiligo, and seborrheic cupitis symptoms. The application of Skinolight is particularly recommended when the skin area to be treated is small or when high-dose ultraviolet B light is required in a concentrated manner. In terms of the intensity of the light, it contains 5% ultraviolet B, 25% ultraviolet A, and 70% visible light. Application of Skinolight. Psoriasis, atopic dermatitis. The first step in Skinolight phototherapy is to determine the minimal erythema dose, or MED value, tailored to the patient's needs. The device contains 3 variously sized endpieces. For making an MED determination, use the 1 by 1 cm endpiece on skin not exposed to sunlight. According to the Fitzpatrick classification of patient skin type, illuminate the skin at 5 adjacent skin areas for gradually increasing periods of 1 to 8 seconds, according to Table 1 of the therapeutic protocol. "24 hours after illumination, determine the patient's individual MED value in seconds for the illuminated skin area where the erythema is first visible. Depending on the extent and location of the skin symptom, we can administer the treatment with a 1 by 1 cm or 2 by 2 cm endpiece and the endpiece for spotlighting. Knowing the patient's MED value and using the required endpiece, we can set and increase treatment times for both psoriasis and atopic dermatitis according to the tables in the therapeutic protocol until the skin symptom is relieved. For each endpiece, both ultraviolet B doses, which are expressed in millijoules per square centimeter, and treatment times can be found in Table 2. For vitiligo, there is no need for an MED determination, since the MED values for normal skin and for skin with vitiligo are entirely different. The treatment time depends on the size of the endpiece and the body region to be treated. The eye contour must be treated with special care, as this is where the skin is the thinnest, and therefore sunburn-like skin symptoms may occur here more frequently. The required number of treatments and treatment duration. Treatments must be administered 2 times a week for each indication with at least a 48-hour interval between treatments. In the case of psoriasis, 10 to 12 treatments are necessary on average for a period of 5 to 6 weeks. For atopic dermatitis, normally 8 to 10 treatments are needed within a period of 4 to 5 weeks. Vitiligo patients must even be treated for several months before any repigmentation can be observed. Patients that react well to treatments can even continue for several years. In each indication, prior to each treatment, spread paraffin oil onto the skin to be treated in order to help light penetrate into the skin. In order to relieve the erythema and the burning feeling that present as side effects between treatments, the use of cooling ointment is recommended, while in the case of an inflammation, use steroid externa. The combined use of photosensitizing drugs. Obligate photosensitizers. Tetracyclines and derivatives, for example doxycycline. Skinolight may not be administered by any means to patients taking such drugs. During the Skinolight therapy, vitiligo patients are not allowed to be given retinoid either. Facultative photosensitizers. Amiodarone, cordarone, and derivatives, which sensitize primarily to ultraviolet A. Furosemide and derivatives. Digitoxin, doxepin, trimethoprim, chlorpropamide, piroxicam, promethazine, retinoid. Patients taking the above drugs can be treated with lower amounts, the appropriate dosage, and special care. Advantages of Skinolight phototherapy. Local phototherapeutic treatment is safer, and it allows for the administration of a higher dosage on the skin area to be treated than phototherapy that affects the entire skin surface. Compared to the other ultraviolet phototherapies, skin symptoms can be effectively reduced using Skinolight with a lower ultraviolet B dose, presumably due to the combined biological effect of ultraviolet B, ultraviolet A, and visible light. Finally, let's take a look at some photos of patients treated with Skinolight.